My name is Tara Montgomery. Welcome to the opening keynote of Day 2 of Preventing Overdiagnosis. I'm a member of the scientific committee, but I'm not a researcher or a clinician. I'm a citizen. And it's in that capacity that I'm really excited to chair this panel on a topic that means a lot to me and that connects really well to what we heard yesterday from Fee Godley on sustainability and lessons learned from COVID-19. That is not to say that COVID-19 is over and we have all the answers and all the lessons, but the first year was particularly intense and we learned a lot about what happens to a health system during a pandemic. So I'd like to turn to an acknowledgement. I'd like to acknowledge the traditional territories of the people of the Treaty 7 region in southern Alberta, which includes the Blackfoot Confederacy, comprising the Siksika, Piikani, and Kainai First Nations, as well as the Tsuut'ina First Nation, and the Stoney Nakoda, including the Chiniki, Bearspaw, and Wesley First Nations. The city of Calgary is also home to Métis Nation of Alberta Region 3, so we acknowledge that as we hold our conference in this space. So I'd now like to, and I'm honored, to introduce 3 women who've had an incredible impact on our movement. They'll bring different perspectives on sustainability of health systems and lessons learned from COVID-19. I'll just name them all, and then we'll invite the first of them to come up. So we're going to hear from Mina Johansson. She's the director of Cochrane Sustainable Healthcare, and she's a general physician in Sweden. Then we'll hear from Deborah Korenstein at Memorial Sloan Kettering Cancer Center in New York. And finally, we'll hear from Wendy Levinson, who's a faculty professor at the University of Toronto and chair of and founder of Choosing Wisely Canada and Choosing Wisely International, and someone whose name came up quite a lot in the last session last night. So it'll be great to hear from her directly. We also welcome everybody who's joining us remotely. You will have a chance to submit your questions through the app, and we will make sure that we hear your questions and bring them to the floor, in addition to everyone in the audience. We're going to hear from all the speakers, and then we'll pause for Q&A for everyone together and have a bit of conversation around the answers. So without further ado, I want to welcome Mina to come up. Thank you, Mina.
Thank you very much. Okay. So I found it. Thank you. Thank you. It's a true honor to be here. I have no conflicts of interest or no relevant conflicts of interest. The pandemic has undoubtedly caused massive harm, but today I will focus on a possible silver lining. In this talk, I will argue that the way we practice medicine today is unsustainable. Patients are overwhelmed by a tsunami of diagnosis and medical interventions, yet do not get the care they need. Clinicians are burned out by recommendations, performance indicators, quality metrics, incentives, and penalties. Yet we are unable to care for our patients the way we would want to. Societies spend an ever-increasing proportion of our societal budgets on healthcare. Yet this is unlikely to be an effective strategy to improve the health and well-being of the population. The current trajectory of medicine is just not sustainable. However, the pandemic has helped us, or maybe forced us, to understand healthcare as a finite resource that we all share as a community. And this means that we have a unique opportunity to rethink medicine and push for a more sustainable healthcare. A healthcare that helps patients with the things that matters, that facilitates instead of hinders clinicians to care for their patients, that maximize our profession's impact on the health and well-being of our communities, and that does not waste societal resources. But to do this, we need to develop better and much more patient-centered methods for prioritization of the time, energy, and money that patients, clinicians, and societies spend on healthcare. A recent systematic review from Ray Moynihan and Loai Albarconi and their team found that overall healthcare utilization, including visits, admissions, diagnostic, and therapeutics, decreased by about a third during the pandemic, with greater reductions among people with less severe illness. Deborah will talk about this in a moment, so I won't get into the numbers. But how did this happen? These unprecedented changes of what we do in medicine and how we do it primarily took place at the forefront of medicine. This happened in our clinics and in our communities. As Tara said, I'm working as a family physician in a small town on the Swedish west coast. And this is our clinic. It looks really boring, but it's actually quite amazing. In our work, the pandemic caused almost overnight a massive change in culture. Our patients suddenly started to ask, do I really need to go to the hospital, or do I really need to do this MRI? Specialists started to question our referrals and asked if the patient really needed to see them. Radiologists actively recommended against controlled scans of incidental findings. I don't think I've ever seen that before the pandemic. We all, quite suddenly, became much more open to a hands-off approach. And this was partly because people realized that hospitals can be dangerous places. They wanted to avoid getting COVID. But a fear of getting COVID was not the only reason. Before the pandemic, we seemed to understand and talk about healthcare as something infinite. But the pandemic has changed our language. Discussions about healthcare today is to a much larger degree than before, permeated by an understanding of healthcare as a resource that if one person uses it, there will be less left to use for someone else. The sudden surge in need of ICU beds made it clear that if I take up one ICU bed, there might not be one left for my mother if she needs one. The sudden cut in resources for non-COVID care made it clear that if one person gets a surgery or an MRI, it means that another person might not. In this survey from the UK, 20% of those who felt they needed a general practice appointment in the last 12 months said that they avoided that appointment because they were worried about the burden to the NHS. And some of these people were likely hurt by not receiving the care that they needed. So I'm not saying that this is necessarily a good thing. But my point is that the pandemic has made the general public acutely aware that healthcare is a finite resource that we all share. Of course, healthcare has always been finite. But by putting this into sharp relief, I believe that the pandemic has opened up a new and broader understanding of the meaning of costs. Beyond money, cost effectiveness, and health economy analysis, the pandemic has made us understand that cost is not only about money. In fact, I would argue that cost is not even primarily about money. Opportunity costs causes real harm to real people. And to be clear, with opportunity costs, I mean what we forego when we choose one action over another. Sometimes, the most important harm of overdiagnosis is not the harm it causes for the individual being overdiagnosed. Instead, it's the opportunity costs. In this study, all imaginable risk factors for cardiovascular disease were measured in the whole population in a geographical region in Norway, and European CVD guidelines were then applied to this population. And the authors found that over 80% of the total adult population, it's the fraction colored red in the graph, would be labeled as in need of medical attention to decrease their CVD risk, according to the guidelines. And the consequences of this is absurd. The number of GPs needed to deal with only hypertension would be greater than the total number of GPs available. So this means that if I would follow these guidelines for the 1,500 people that I serve in my GP practice, I would have no time for patients with any other diagnosis or symptoms, such as, for example, suicidal thoughts or symptoms indicating cancer. And there are many similar studies showing the same thing. Clinicians face a tsunami of recommendations with no possibility to follow more than a tiny fraction of them. And this problem is to a very large extent caused by overdiagnosis, through lower thresholds for diagnosis and interventions, and by medicalization of ordinary life experiences. So, my point is that the most important harm from this case of massive overdiagnosis is not the labeling and overtreatment of each individual. Instead, it is the opportunity cost, which would substantially limit access to high-value care for the vast majority of individuals within this community. And I think that this study illustrates very well that even in high-resource settings, this problem cannot be solved by more money. Similarly, the main harm of overdiagnosis for the individual is not always the direct effect of each diagnosis. In fact, one of the major challenges when dealing with overdiagnosis for both clinicians in clinical practice and patients in their everyday life is the cumulative burden of all diagnoses combined. This study is based on the same population as the previous slide. All chronic diagnoses for the whole population in a geographical region in Norway were recorded, and the authors found that over 40% of the adult population, the red and pink fraction in the graph, have multiple chronic diagnoses. Our system is very good at generating diagnosis, but less good at figuring out which diagnoses actually bring meaning to the patient. And this is not a problem that is isolated to the really old or really fragile. Amongst patients in both primary and secondary care, multiple chronic diagnosis is the rule and not the exception. So, the point I'm trying to make is that the consequences of overdiagnosis are heavily underestimated when we understand each overdiagnosed condition as an isolated phenomenon, because we miss the cumulative opportunity costs. In other words, clinicians are not the only one hit by the tsunami. I counted the number of recommendations in NICE guidelines that applied to each patient I met during a day. And it was on average 76 recommendations per patient, of which many are tied to financial incentives or quality metrics. And me and the patient usually have maximum 20 minutes together. In this context, it's not strange that patients are interrupted by their clinicians within on average 11 seconds, nor that 40% of patients with chronic conditions reports feeling overwhelmed and unable to sustain current investments of energy, time, and money in healthcare. In most of my consultations, it's a struggle to not lose sight of the patient. And that is something that never ceased to shock me. How can we accept a system where clinicians have to actively and courageously ignore the guidelines, revenues, and quality metrics that are supposed to improve the quality of care, to even have a chance to see and truly listen to the patient in front of them? To tie this back to the pandemic, when COVID hit us, it was suddenly accepted and even encouraged to ignore administrative demands and unreasonable guideline recommendations and quality metrics, and instead focus on what really mattered to the patient. We suddenly began to enact what we have known for a long time from experiences in palliative medicine. the importance of carefully considering the benefits and harms of every intervention and diagnosis, not just in terms of biomedical outcomes, but also in the social, psychological, and existential experience of the patient. In other words, the pandemic forced us to try to distinguish between what brings meaning and is helpful to the patient and what is not. But did we quit only the unnecessary stuff, or did we also stop doing the things that patients would have benefited from? I believe that it must be questioned whether we got it right. Our unsustainable system must change, but this change needs to be thoughtful and evidence-based, and not just reactive. So in this talk, I have argued that we need a new way of thinking about prioritization of resources in healthcare, that we need to become much better at carefully considering and appreciating opportunity costs in terms of time and burden for both clinicians and patients. But how can this be done? I believe that we need to make these costs explicit. And as a step in this direction, I am, together with Victor Montori and Gordon Guyot, developing a new method to help guideline panels to more explicitly consider how much clinician time is needed to implement their recommendations. We are calling this concept TNT, time needed to treat. And TNT considers the time needed to provide the recommended intervention to each individual with a fraction of the population eligible for the intervention, and is then expressed in relation to the effectiveness of the intervention and as a proportion of the available clinician time in the relevant context. We estimated TNT for the NICE guideline recommending GPs to give brief advice to all patients on physical activity to all adults with a sedentary lifestyle. And according to our estimates, 3 hours of GP time would be needed to improve self-reported physical activity for one person. For a GP practice, this would translate into 167 hours per year, which in turn would translate into 15% of all the time that GPs in the UK have face-to-face with patients for all causes. So after making such costs in clinician time explicit, guideline panels must consider if it's reasonable to recommend GPs to spend 15% of their total time available for patient care on an intervention known to improve only self-reported physical activity, which is, as you know, an outcome prone to bias. And the aim with this exercise is to help facilitate for guideline panels and policymakers to make a conscious prioritization of clinician time. Because today, clinicians are left with no other choice than to select which of the myriads of recommendations and for which patients to follow and which to ignore. And since we get little help with this prioritization, it's often made arbitrarily and implicitly. So these are very rough estimates, and TNT is a simple method that needs to be further refined. But the point I'm trying to make is that a thoughtful prioritization of healthcare resources does not have to be complicated. I believe that key is to start thinking, estimating, and communicating about the human costs of opportunity costs, because these are easy to spot if we want to. I imagine that some of you might think that I'm a bit naive, and perhaps you have a very different experience than what I have presented here. Of course, there are many examples all around the world of when health systems, clinicians, and patients have reacted to the pandemic in the opposite direction, by redistributing resources from disadvantaged to privileged groups, or to interventions with uncertain benefits for the individual. Many patients have missed out on care that they needed, with sometimes devastating consequences. I have seen this myself firsthand in my own clinic. But even if this is true, it does not mean that we don't have a window of opportunity. And I believe that we should use this opportunity to build momentum. Because the pandemic has helped us understand that healthcare is a finite resource, and that costs is not primarily about money, but that opportunity costs cause real harm to real people. The current healthcare crisis, with prolonged queues and healthcare debts, has made it absolutely clear that we need to develop better, more transparent, equitable, and much more patient-centered methods for a thoughtful prioritization of the time, energy, and money that we spend on healthcare. The pandemic has put into sharp relief problems that were here long before COVID, and that will still be here long after the pandemic is gone. But never before has there been a better opportunity to change what we do in medicine and how we do it. Finally, I'm establishing a global center for sustainable healthcare and hope that many of you will join me. This is just in the beginning. Website will be up later this year. In the meantime, feel free to reach out to me on this mail. Many thanks for listening.
Thank you, Minna. Now we're going to move to a Zoom participant on the screen who will hopefully pop up momentarily, Deborah Korenstein, who will be our next panelist. And you can see Wendy as well. Hi, Wendy. You're on screen, but we're hearing from Deborah.
Good morning, everyone. Can you hear me?
We can hear you, but the microphone is far away, so if you don't hear from us, that's why.
Okay, thank you. So good morning, everyone. And I'm sorry for having to do this remotely. I'm very sad not to be there with you in person. I'm going to share my slides. Hang on one second. All right, are you seeing my slides?
We are seeing your slides, and we can
Great.
see your faces as well.
Okay, great, thank you. So I'm going to really springboard off some of Minna's talk and talk about what we've seen so far in care appropriateness during the pandemic. So I have no conflicts of interest to declare. My husband does serve on 2 scientific advisory boards and does some consulting work, but it has nothing to do with what I'm speaking about. And to be totally honest, I don't actually understand any of it anyway, so it couldn't possibly bias what I'm saying. So COVID completely upended healthcare delivery, as we all know. And as Minna pointed out, this has given us an opportunity to think about resource prioritization and to really think about whether we're getting it right. So, I think that the pandemic may have enabled really right-sizing healthcare by reducing overuse and overdiagnosis, therefore, and improving equity, but it also may have done the reverse. So I'm going to show you some evidence about what we know so far around these issues, talking first about just utilization, then about the appropriateness of the utilization, how that all impacts clinical outcomes, and then how it varies across groups. A couple of caveats before I start. The evidence is really very incomplete still. We know very little. Many of the studies really look at through 2020 and not much beyond. And there's very, very little published data from low and middle income countries. I think that's something we need to keep an eye out for going forward because the impact may be very different in those places. The evidence I'm going to really talk about comes really from Western developed countries. So I'm going to start with utilization. We know the pandemic led to much dramatically decreased utilization of many, many services. So this is from a global systematic review that looked through 2020. You can see from February to May here, from the left to the right. And across the world, there was about a 30% reduction in diagnostic testing. That's what this graph shows, diagnostic test utilization. So that's of all kinds and in all places. So clearly a very large decrease. Similarly, this is data from the United States that also shows a decline in testing from 2020 compared to previously. And it shows that the decline was more in response to remote visits, telehealth visits, but it was not limited to remote visits. So what you see here, the shaded part shows you the COVID rates during this time period from April to December of 2020. And then the darker dots, I'm going to try not to advance the slide while I do this, up here shows you the testing ordering resulting from in-person visits, and in blue is telehealth visits, video visits. And then on the y-axis is the odds of ordering any test. So you can see these are all less than 1, meaning that they're less likely to be ordered compared to pre-pandemic, but that the reduction in testing is much, much more dramatic for telehealth visits, which is really not at all surprising when you think about it. The patient's not there, you can't really do testing, or it's way more of a hassle to do any tests. So that's not surprising. And also not surprisingly, fewer tests has meant less screening. And a lot of the attention around services during the pandemic has really focused on cancer screening. And I'm going to talk quite a bit about that in this talk. So this is US data. And this is comparing screening rates in April of 2020 compared to just before the pandemic in February of 2020. And you can see for breast cancer, colorectal cancer, lung cancer, and cervical cancer screening, rates went down very, very dramatically during the peak of the pandemic during shutdown. So these declines also did not fully recover. And most of the data we have only goes to the end of 2020. But this again was found in many, many places. This study is from Ontario, and it compares screening rates in 2020 compared to 2019. So on the top, you see breast cancer screening for average risk on the left and high risk patients on the right. And at the bottom, you see cervical cancer screening, colorectal cancer screening rates for average risk patients on the left again, and high risk on the right. And 2020 is in the black, and 2019 is here in gray. And you can see clearly really dramatic decreases in screening that really didn't recover, with the exception of high-risk breast cancer screening. And what you can also see for high-risk breast cancer screening is there's a little bit of catch-up, meaning that the 2020 rate then surpasses the 2019 rate to kind of make up for all those people that missed screening in the earlier months. And we do see that for high-risk breast cancer screening here, but we don't see it in any of the other cases. And in general, in these studies across the developed world, we're not really seeing any catch-ups. The idea is that all these people who miss screenings are not then getting it later, or we're not seeing that anyway. It's just a completely missed screening. So we know there's less testing, as I just showed you, but this could be either good or it could be bad. And as Minna kind of alluded to, if what we're eliminating is unnecessary excessive testing, and we're continuing to do useful testing, that would be really great. But if the opposite is true, then it's not so good. So what do we know about utilization and appropriateness of testing? So when we think about this, and to understand impact, we really have to think about the appropriateness of the delivered care and also who was impacted. So when you think about this graph, sort of shows the relationship between the amount, the volume of care on the y-axis and the appropriateness or benefit of that care on the x-axis. So the green line represents kind of the sweet spot, where over here on the left, where the care is not, sorry, I can't use my cursor because it keeps advancing the slides. Over on the left, where the care is not so appropriate and not beneficial, we're not doing much of it. But as you move to the right and the care gets more beneficial, we're doing more of it, kind of across a population. This is kind of a bird's eye view of utilization. But what we know from other studies is that doctors tend to have a set point for care, meaning that there are people who are just high utilizers, and across all kinds of patient types and across maybe all kinds of services, they just tend to do a lot of stuff. And as clinicians, I think we all know who those people are. This is something that's very recognizable and intuitive to people. So those people, when you think about needed care, they tend to provide it because they provide a lot of stuff, but they also tend to overuse and provide care that isn't necessary. On the other hand, lower down, we have the lower utilizers, and I am one of them, and probably many people in the audience are like this because we're interested in this topic, who tend not to overuse, but also may, unfortunately, the literature shows, underuse needed care. And so the question is, in the pandemic, did we just drop everything and do less care across the care spectrum? Or did we use this opportunity that Minna talked about to really right-size care in a better way? So, we don't know the answers to this. I think a lot of this is really up for discussion, but I'm going to show you what we do know. So there's a little bit of evidence about this. So let's dig in a little bit to what pandemic reductions look like. So across the board, this is a graph from a systematic review done by many authors who are probably at the meeting, if I could see you all, of global testing in 2020. And they looked at whether the reductions in testing compared to pre-pandemic were for milder cases. And that would suggest that what we're avoiding is the less necessary care. So that would be a good thing if the reductions were in people with milder disease, or were the reductions in kind of across the board and did not reflect patients with milder disease. So what they found is, as you see on the left, in about 45% of the included studies, the reductions in utilization were in milder cases. There were greater reductions in milder cases than in more severe cases, which is good. But in 55% of studies, that was not the case. There was no difference based on disease severity, suggesting that it was more what I showed on the last slide, where utilization just dropped across the board. And here's a specific example from one study. This is a US-based study. The systematic review was really international, but this is a US-based study that looked at CT films in the emergency room in people with abdominal pain. And what they looked at is whether those CTs showed complicated diverticulitis or uncomplicated diverticulitis. And the idea is that if there were fewer CTs showing uncomplicated diverticulitis or milder disease, it was likely that we were doing fewer of them in that milder disease, and those probably weren't necessary. So what that would suggest is that the reductions that we see in utilization were for people who really probably didn't need a CT in the first place. But if we found a big reduction in complicated diverticulitis, that would be probably not a good thing, because those are patients who probably really do need the CT scan and are sick, or at least need care in some way. So what you see on the left is that CTs showing uncomplicated diverticulitis dropped pretty dramatically. And the dotted lines outline the period of shutdown during the height of the pandemic. So a really very large reduction in uncomplicated diverticulitis cases. But on the right, a much smaller reduction, and maybe during that entire time period, not even a reduction in complicated diverticulitis, suggesting again that we were doing something toward right-sizing care. We were not doing the tests that were really probably not necessary, or at the very least were less important. But the real question is how all of this impacts clinical outcomes. Because if we reduce utilization and we don't harm patients, that suggests that there's actually net benefit to that, and that we're reducing utilization in a way that makes sense and is beneficial. Now, the evidence here is really emerging and really unclear and somewhat contradictory, but I want to show you a couple things that we do know. So this is from a population-based study in Sweden looking at antibiotic use during the pandemic and complications. And the idea is that if we were reducing antibiotic use in a way that we were not giving patients necessary treatment, we should see more complications of bacterial infections that were not adequately treated with antibiotics. So what you see here on the left is antibiotic use in 2020 over the year. And again, beginning around March is the height of the pandemic, the shutdown, the lockdowns, and the different colors show you different indications for antibiotics. So that bluish green is respiratory tract infections, which is a very large volume of antibiotic use, that's not really indicated on this particular slide. But you can see pretty dramatic reductions in antibiotic use, particularly for respiratory tract infections, and reductions across the board for all antibiotics. And with the exception of respiratory tract infections, it looks like maybe it's recovering towards the end of the year. But what we see when we look for complications is no increase in complications, and in fact, a lower rate of complications during the pandemic compared to pre-pandemic for anything that, that would have been related to lack of appropriate antibiotic use. So this is really encouraging, suggesting that the pandemic was an opportunity to reduce unnecessary antibiotic use, and it did that without any harms to patients. So that's really, really encouraging news. And it may be that different services kind of worked differently during the pandemic. But unfortunately, there's another example that shows the opposite, also related to infections. So this is a systematic review of global rates of perforated appendicitis in children during the pandemic and compared to pre-pandemic. And what they found was that rates of perforated appendicitis at the time of surgery were substantially higher during the pandemic compared to before, rising from about 29% to almost 40%. So that's bad. That suggests that children were not getting early enough care to prevent perforation for their appendicitis. So it's a little bit, it's a little bit of a different clinical scenario, but showing that at least some of the lower utilization during the pandemic actually had harm. But like I mentioned before, a lot of the focus around these issues has been on cancer screening and cancer diagnoses. So I want to show you some evidence about that. So this is from a study in Ontario, comparing 2020 diagnoses through September to pre-COVID cancer diagnoses. And what you see is across the board, there were fewer cancers diagnosed. And above the blue line, these are cancers that we screen for. So it's not at all surprising that if there were less screening going on, there would be fewer cancers identified. And you can see that those reductions are pretty dramatic, 69% fewer breast cancers. This is like sort of a relative risk reduction, very large. But you also see below the blue line, there were similar reductions in cancers for which we do not screen, suggesting that patients were not coming in with complaints that would then lead to a cancer diagnosis. And it's not clear, the ramifications of all of this are unclear. Just not diagnosing cancer may be beneficial or it may be harmful. In the case of something like breast cancer, where many cancers are overdiagnosed, this reduction may be beneficial to patients. In the example of melanoma, it might be harmful to patients if we're not diagnosing earlier stage melanomas that could be curable with simple resection, and instead patients are presenting with metastatic melanoma, which is much less treatable. Interestingly, in this study in Ontario, there was no difference by socioeconomic group, which is important. It may be system specific, those issues around socioeconomics, but it's at least encouraging that in Ontario, there were no differences. Similarly, there were similar findings in Wales looking at screened cancers, breast cancer, colorectal, and lung cancer, showing 2020 in the lighter gray with many fewer diagnoses. But again, it's hard to know what all of this represents. What we know so far, what we really need to understand it is very long-term data on it, because it takes years to see implications clinically from fewer cancer diagnoses. What we do know is that in data from Montreal, there's a shift toward higher stage colorectal cancers at diagnosis in 2020 compared to 2019. So that implies that there could be clinical harm, because that may impact the treatments that are needed and in fact the rates of cure for colorectal cancer. In the US, interestingly, in 2020, we've seen slight increases in breast and colorectal cancer mortality. I think that is probably not related to screening differences, because it would take far longer to see any mortality difference related to less screening. But it probably suggests that patients with cancer had more difficulty accessing care during that time for a variety of reasons. And so that could represent real harm to those patients. But like I said, we need much longer term data. And several groups have done simulation studies. This is from a Canadian one, looking at sort of trying to predict what's going to happen in cancer deaths as a result of less screening. And this got a lot of media coverage. I feel, I'm not sure, I can't remember when it was. The pandemic is a bit of a blur, but during the pandemic that, there was sort of a little bit of hysteria that all these people aren't getting screened and it's going to be terrible and lead to all these deaths. So this slide shows predictions for 15-year mortality, so over the long term, based on a 12-month interruption in screening for breast and colorectal cancer on top in gray, a 6-month interruption in blue, and a 3-month interruption. And, what these are showing is pretty substantial excess deaths over time, particularly for colorectal cancer. You can see the numbers on the y-axis are a bit different. But a lot of these studies don't really take into account potential harms from screening. And we have to take it a little bit with a grain of salt, and it really remains to be seen what will happen. So finally, I just want to end by mentioning variation in the impact across groups. We really don't know much about this, but I want to mention it because there's a sense clearly from COVID itself, more vulnerable populations have suffered much more. And I think there's a sense that the non-COVID issues related to the pandemic also are likely to impact vulnerable populations the most. So there's very little published about this. I'm just going to show you one study. This is from the US, from a statewide community health system in Washington state, that shows disparities in the reduction in breast cancer screening in 2020 compared to pre-pandemic by race, ethnicity on the left. And what you can see is whites are over here on the right with the least reduction in screening during the pandemic, and Hispanic patients had the greatest reduction in screening during the pandemic, with other groups in between, suggesting that there were some disparities. And then, this is US specific, but I think it speaks to disparities pretty clearly if you look at insurance type on the right, which shows that patients who self-pay, which essentially means they are uninsured, had, not surprisingly, the greatest reduction in screening. Medicaid patients, as I'm sure you all know, are insured, but they're poor. That's what you have to qualify for Medicaid based on income. So they had the second greatest reduction in screening. So certainly suggests that there are disparities, and I'm sure this is really, really the tip of the iceberg when we learn more in years to come about the impact of COVID on healthcare writ large. So to conclude, we've seen a pretty dramatic decline in utilization of a variety of health services during the pandemic. The impact is mixed. I think probably there has been decline in needed services, but also some decline in unnecessary services and reduction in overuse and also therefore in overdiagnosis. So that could be a good thing. And I think the trick is going to be in sussing out where the impact has been and trying to right size it using this opportunity as Minna alluded to. And I think that there may likely be more harm to vulnerable populations, but that really has yet to be elucidated. So I'm sure there'll be more to come on that. I'm going to stop sharing now and turn it back over to...
Thank you, Deborah. I know you can't see us, but if you could, you would see about 200 people applauding very loudly. So, thank you very much. So now we're going to move on to Wendy Levinson, who will hopefully come back on screen momentarily. Yes?
So I'm here, but it says that the host has to start my video.
Okay. Host, please could you start Wendy's video? Well, we can see you. We can see you.
Okay, great.
All right. So I'm going to walk away from the microphone so you won't hear us from the room, but you're on. Okay. We can see your slides, so we look forward to hearing from you.
It's nice to be here, and actually, we missed the beginning of your talk, Minna, because the room was on mute. But I was very interested in the part I heard, and maybe I can hear more in the questions. And Deb, that was really fascinating. So I'm going to build off their talks, because actually I'm going to flip it and say, how could we use the pandemic to really drive positive change? And I think the question is, now more than ever, we needed to be actually doing things to decrease overuse so that we could keep our precious healthcare resources for the things that were high value. So I'm going to give you like a few examples from Choosing Wisely Canada of where we tried to use the pandemic, or in the face of the pandemic, drive change. Now let's see if I can move my slides. Kennedy, it seems like my slides are frozen. Why don't you bring them? I think you have them, right, Kennedy? Tara, there is a copy of my slides there. I'm going to stop my sharing because it wasn't working. I'll try one more time. So I'm not sure why, but my slides aren't moving ahead, and Kennedy has a copy. Could we bring them up?
I'm sharing them right now.
You're sharing them? Excellent, thank you. Okay, so just slide. I have nothing to declare other than I received support from Choosing Wisely Canada. Next slide. So one of the things that happened during the pandemic is that we knew that there was a donor shortage across Canada. The Canadian Blood Services was quite concerned about this, especially in early 2020, because donors appropriately were concerned about leaving their home and going to donate. And so there was a decrease in blood. We also knew from some preliminary work that the use of red blood cells, in particular, I'm talking about red blood cells, are frequently overused. And so in September of 2020, we launched a campaign called Using Blood Wisely, which was to engage hospitals across Canada in decreasing their use of red blood cell transfusions if they weren't absolutely needed. So the next slide. And what we did is we worked with the Canadian blood community and Choosing Wisely. We had 6 or 7 of our societies in Canada had a Choosing Wisely recommendation on their list that pertained to decreasing blood. And so we had a lot of professional input into this, and we set 2 benchmarks. One of them was only using 1 unit of red blood cells and instead of giving 2. And I always say, like, my whole career, I wrote orders for 2 units of red blood cells instead of 1 and reassessing. And secondly, we set a benchmark around the pre-transfusion hemoglobin. So evidence suggests that we don't really need to transfuse unless the hemoglobin is below 80 or 8, depending on what units you use. And so we set these 2 thresholds of what it was to have appropriate blood transfusion in a hospital. And hospitals that met the designation, I'll tell you more later, met these benchmarks, could be designated a Using Blood Wisely hospital. So on the next slide. What we did then is we went out to hospitals across the country. We asked them to voluntarily audit their practice. If they met the benchmarks, great. They had to maintain them and show them for 4 months. If they didn't meet the benchmarks, then we had a whole program that's on our website that I would encourage you to look at if you're interested in this, to try and get them to bring their transfusion down to these benchmarks. And since that time of late September, early October 2020, a little over a year and a half, we have about 216 of the over 500 hospitals participating, but we do have a disproportionate amount of the large hospitals. And so this represents over 70% of the blood transfused in Canada. We're just analyzing this, but our best guess is that we will reduce the use of red blood cell transfusions probably about 20+%. So I think that's a real, kind of using the opportunity to drive change, because our donor rates were down, and this is a precious resource for society. We donate it. We know that patients can have harm from blood transfusions, of overload syndromes and other reactions. It's extremely costly in Canada. We spend $1 billion a year on purchasing blood, let alone cross and typing and hanging it. And I'd even add the 4th, which might be there's an environmental impact of transporting the blood and all the plastic tubing and stuff that we waste when we give unnecessary transfusions. So this is one example of a pandemic-driven reduction in overuse. Next slide. Secondly, I just want to mention a campaign that we're not as far along on, but we've been involved in, which is Time to Talk. So in the pandemic, of course, this was the first time we think there was sort of a shift in public attitude, that people realized that healthcare resources were precious, that they were limited. I mean, we all knew in Canada that there were serious restrictions on ICU beds, and that this was a big problem. And we also know that in Canada, we're not very good at providing services outside of the hospital in end of life. And that people often get admitted to the ICU, and when really, if you had better services at home, their wishes would be to stay at home. So we used the work that came from the Ariadne Lab in Boston to create a campaign called Time to Talk. And the goal was to try to actually capitalize on conversations that were happening around the dinner table. You know, grandma saying, gee, if I ever get COVID and end up really sick in the ICU, here's what I would and wouldn't want. And in fact, so in the next slide, we got all the societies together that were relevant to this. So in Canada, we have about 85 professional societies. About 35 of them deal with really acute care. Some are not relevant. And they all together endorsed this statement: don't offer tests and treatments without establishing your patient's prognosis, preference, and goals of care. Potentially harmful or overly aggressive tests can be avoided by having discussions about goals and wishes and documenting this information. Obviously, this is not a new topic. All of you in the audience have talked about advanced directives in earlier conversations. But what was really interesting is that a practice in Calgary, and maybe Dr. Reynolds, Janet Reynolds is in the audience. She and the staff called all their elderly patients during the early pandemic to ask, how are you doing? Do you have what you need in this difficult time? And what would be your preferences if something happened to you? And they documented their advanced care directives. On the next slide, we created a lot of materials that came from the Ariadne Labs about conversation guides for this serious illness. And so this is really a second example of something that happened during the pandemic that actually was a program to try to decrease inappropriate overuse, and one where I think the public was tuned in and starting to have these, quote, dinner table conversations. Next slide, I'm going to give you another example. So this is also a really interesting example, and one that's going on at the moment. You may be aware that that there's a worldwide shortage of tubes to draw blood, in the supply chain, and it's anticipated that this shortage will last for a couple of years. So on the next slide, we worked with several of our societies to sort of make this public. We were interested in decreasing the use of unnecessary laboratory testing right from the beginning, because we know that in the hospitals, and we work a lot with the hospitals, many tests are ordered routinely, CBCs in chemistry, daily, tests that are obsolete can still be ordered. In Canada, we have folate in our food. We really don't need to order serum folate. And so we worked with our societies to take advantage of trying to make public, and both to doctors and patients, or clinicians and patients, the critical shortage of blood tubes. And these are just a snapshot of high-profile magazines, Globe and Mail, one of our national journals, and some other magazines that pointed out that hospitals face a critical shortage of blood collection tubes. So on the next slide, and you can just click, and I'll give you an example here. Just click it, please. So one of the Society of Clinical Chemists took all our Choosing Wisely recommendations and went through them to look for recommendations that are big users of laboratory testing. So here's an example. In the inpatient setting, don't order repeat CBC and chemistry in the face of clinical stability. That was our recommendation before the pandemic. Then they added these little statements. Do you know that just one blood drop per day of routine testing can add up to removing a half a unit of blood per week? And the result is 20 to 30 blood tubes wasted and iatrogenic anemia that has a negative effect on outcomes. And these do you knows were really kind of startling to our clinician professionals who, I certainly didn't know some of this. Plus they often added use of human resources in the lab, because in our settings, we had a shortage of healthcare professionals. And in the labs, there was a big shortage, plus the demand on the labs was huge during COVID. So these do you know that also included things about how much technician time it could do to do those tests. So I'll give you an example. I never knew that it takes quite a bit of time to do a SED rate, an ESR. I learned that in this context. And then we tried to promote these messages to the relevant clinician communities like general internal medicine for this, or others that would be highly relevant. And we had a list in both the inpatient setting and the outpatient setting. So on the next slide, what we've done with this is tried to create a growing program across the country to bring hospitals together who are interested in working on this. And what's required is that the hospitals, we've done it with 23 hospitals so far, and we plan to roll it out more in the fall. They submit their data, they agree to do quality improvement, and most importantly, and I think this is really a key thing I've learned is, that they participate in a learning collaborative. And what's really interesting is that there's so much cross-learning, because some hospitals have eliminated low-value tests like serum folate, and other hospitals haven't. And so they learn from one another, well, how did you do that? And what were the challenges? And how can we get beyond that? Next slide. So just a last moment, because I want to leave enough time for the conversation, is we've tried to tackle some things during the pandemic, grassroots up, because choosing wisely is very grassroots. But we realize there are also system barriers to reducing overuse. And I think the pandemic has also made it obvious that we need both the grassroots to work on this, and we need the system levers. An example of a system lever of low value in our setting is that many provinces in Canada, orthopedic surgeons are required by law to send tissue from hip and knee surgeries to pathology. But they're always benign because they're not being taken out for a malignant or abnormal reason, and they back up the labs. But we can't fix that individually. We have to fix it at the system level. And so I think now we plan to work more with policymakers to look at ways we can decrease these unnecessary lab tests by having criteria. So you have to say why you're ordering a vitamin D if it's just a routine and it isn't about someone with a malabsorption or rickets or some indication, then it won't be processed by the lab. Or removing outdated tests, or building systems so we don't order a hemoglobin A1C 1 month after it was ordered because we know it doesn't change quickly. So I think we have to change some of these issues of overuse can't be dependent on the doctor and patient or the clinician patient. They need a systems approach. And we've tried to leverage the system during the pandemic to try and decrease low value care so that this very overworked behind system can catch up, or at least have the capacity to do the things Deb talked about, the needed screening on the higher risk people instead of the people who don't really need a mammogram because they're really not even in the range, age range, or it's not what they would wish. So next slide. I think I'll stop there. I think this is my last slide, I think. Maybe you can pull those slides down now, Kennedy, and we can just get into the conversation.
Yeah, is my mic on? Thank you very much, Wendy. I love that did you know thing. I thought it was genius, really impactful. So let's give Wendy a round of applause. And if we could bring Deborah back on screen for our Q&A, and I'll invite Mina to choose a seat in the room in front of a mic. And the two other imaginary mics are the people on the screen. Do you want to test your mic? Make sure it's working.
Hello, can you hear me? No?
Yeah. We might need to have help turning it on. Yeah, someone's coming.
No.
Okay. So can you hear us, Wendy and Deborah?
Yeah.
Yes.
Okay. So what we're going to do is we have help with a mic going into the audience to answer questions. So anyone speaking into the mic with a question you will hear. And then occasionally we will go into the online Q&A and see if there's anybody asking a question there. We're just getting Mina set up.
Can you hear me now? Yes, great.
Okay, hold on a sec.
Maybe we could also have a chance to respond to one another or ask each other questions if there aren't any immediately, just to get things going.
Yes, we have a question from Barry Kramer.
These comments are addressed to Dr. Korenstein, and first let me say thank you very much for a great talk. I completely agree that there's a big need for long-term longitudinal data. But I'm going to talk a little bit about emerging data that seems reassuring right now. A paper just came out a week ago by Fadiwa and colleagues, which they say is the very first population-based survey of screening behavior during the pandemic, as opposed to nearly all the available data, which is screening center or referral hospital-based data. And they point out a few important things. First of all, when you look at reports of screening activity, it doesn't take into account that most of the screening tests have a substantial interval, recommended interval. Breast cancer, about 2 years, not immediately, and so changes in pattern over a few weeks or months may not reflect being up to date in screening. Colonoscopy is 10 years, cervical cancer is 5 years, and I'll point out that in the case of screening for melanoma, as far as we can tell from population-based data, screening leads to an increase in superficial, thin melanomas, but not to a decrease in metastatic disease. So I think we can be reassured that changing in screening, that's a big overdiagnosis area. But what they point out was that, in essence, at the population level, screening behavior for colon cancer remains steady because colonoscopy appeared to be replaced by at-home FIT testing. Mm-hmm. And since we still don't know which of the two tests is superior, it's unlikely that there's going to be a major cost in terms of colorectal cancer mortality given the emerging data. And finally, what they point out is when they ask people, these are self-reports in a population-based survey, they ask people if they had a screening test in the prior year, but also if they were up to date. In other words, for mammography, had they been screened in the last 2 years and so forth. And they point out that there was virtually no change and no evidence of a decrease in people being up to date. So the data is early. I think you stated it absolutely correctly. We need longer term follow-up. But at this point, I think there's emerging evidence that could reassure us.
Thank you. Deborah, is my mic on? Mm-hmm. Hello. Why don't you respond to that comment and that insight, and then I'll see if anyone has anything to add.
Sure. Thank you for that, and thanks for adding that more recent data. I totally agree with you. I mean, I think that the intervals are not really reflected in the evidence I showed, and there could have been catch-up. And thank you for also pointing out the shift from colonoscopy to stool-based testing, which could be really a very good thing on balance. And I think you bring up the point that it's important to think about this in terms of the ultimate impact on patients. So again, thank you for that. The one comment, when I mentioned melanoma in that one study, that was not being screened for. It was just fewer diagnoses of melanoma. So those would have been diagnoses made in clinical care and not through screening, just importantly. Again, I have no idea how impactful that was, though.
No. Anyone else want to add to that? Or we can move on to the next question. Okay. I'm going to bring in a question from the online audience that Thomas is going to share with us. We're just putting on his mic.
Yeah. There are just one thing to Wendy first. Can you please share a link to the Did You Know laboratory recommendations? So this is just
it's just if you go to the Choosing Wisely Canada website and you put in, if you search laboratory testing, it pops up. I forget exactly where the link is, but I can try and find it during another question and put it in the chat box.
Okay, thank you. So the second goes to Mina. I don't know who is writing, but it's written, TNT is an explosive concept. I love it. What does the 3 hours consist of?
Yeah, so it's the recommendation. GPs are recommended in the guideline to screen everyone for sedentary behavior, and then the ones that don't exercise enough, they give advice, are recommended to give advice on to exercise more. So we basically made an estimate of how much time that would take, the screening and the intervention, and then multiplied that with the proportion of the population. And for the 3-hour estimate, it was related to NNT, so how much time it would take to improve the outcome for one person.
Let me ask Wendy and Deborah, do you have any thoughts on the time needed to treat?
Yeah, I was going to comment on it, if you don't mind if I jump in for a minute, Deborah. I thought it's really an interesting concept, Minna, and one of the things that occurred to me is, you know, when we do unnecessary tests, like I'll just use the laboratory test as an example, they lead to false positives. And then we have more tests that we have to do, which lead to follow-up time and a lot of communication with the patient to deal with that cascade of tests. And our malpractice carrier in Canada says the reason doctors get sued, one of the common reasons is they don't follow up on laboratory testing that is abnormal. So often doctors say, well, maybe I'll get sued if I don't order a test. In fact, the opposite is true. They get sued when they order a test and it has an unexpected result, but they don't really pay attention to it. So I guess a part of what I think is really interesting is sometimes dealing with all these things we do that aren't needed is a time sink for doctors. Have you thought about that in your calculation?
Well, I think that, can you hear me? Yeah. I think that, I mean, making these estimates is very complex for complex interventions, and for these kind of cascade effects, it will be very uncertain. Like estimating the time needed will be lots of uncertainties in such estimates. But I think that shouldn't stop us from doing it. We should understand that it's uncertain, but we need to do it because we're in this situation where it's just this tsunami of recommendations that are impossible to follow. So we need to do something about it. And I think one problem when we talk a lot about low value care, and of course that's the stuff that is obvious that we should stop with that's really evidence-based, that it's low value, is very important that we stop with. But I think the problem is much broader than that. I think that we need to integrate all the way from primary research, evidence synthesis, guidelines, and policymaking, and in the clinician, just become much better at prioritization, because currently we just are very, very poor at medicalization, at prioritization. It's not embedded with modern medicine, and I think that's key. And that way of thinking is principally a bit different from dividing it into low value and high value care, I think.
Deborah, do you have anything to add?
No, I agree that it's fascinating and a really great concept. I think both in terms of prioritizing all of the routine stuff that you're supposed to do in primary care, which I agree, as a primary care doctor, there's no human way to do all the things that you're supposed to do. And also as a way to think about other interventions that aren't just preventive care as it's just another metric. I feel like the word metric is loaded, but another way of measuring the impact of what we do. So I think it's a really fantastic concept. I'm so glad you're working on it.
Thank you. I mean, of course, I don't think that's the solution to all of this. I'm just saying it as an example of how this could be done in fairly easy ways, some of it.
Great. So there's an audience member holding a mic, and I'd love you to ask a question.
Hi, I'm Janet. I'm a family physician, and my clinic is just up the road. I feel a lot of...
Hi, Janet.
Hi, Wendy. I feel a lot of distress because I'm inspired and I'm also overwhelmed with your talk. Do you have any... Monday, when I go back to my clinic, where I have probably 200 tasks that will accumulate over the weekend, do you have any practical tips around this prioritization for our limited resources? Because we are struggling with this surge in requests for care post-pandemic, and sort of the knowledge translation around how to get rid of the low-value care.
Yeah.
Let's have Minna respond first.
Yeah. Well, I think that we need to acknowledge that we are prioritizing now. Even if it's implicit and arbitrarily, we are doing it now. So we are choosing not to treat some patients. We're choosing not to follow some of the recommendations, or quite high proportion of it. And I think this relates to the talk about equity yesterday. And one of the speakers said that just because we stop doing the low-value care, it doesn't mean that we necessarily spend this time on disadvantaged groups that would need it the most. And I think that's very true. I think that we as clinicians, we need to take this in our own hands and do some resistance. Like, we are not victims. We can decide what we want to do. I think that we need to make the prioritization consciously ourselves. Like at my health, I understand that it's different circumstances for everyone, and it's not easy. But at my healthcare center, we work really hard and really clear on how to increase access for disadvantaged groups, how to spend most time on the interventions and patient groups that benefits from our time the most. And then that needs to do that. We need to say, we won't do this, or we will prioritize this much less. And some patients are angry with that, but we do it anyway, because if we don't do it, we still do the prioritization. Like, we are still responsible for it, even if it's not something we decide. So I think we should be a little bit braver and a little bit more doing more sort of uprising. It's not easy, and every system has different ways. But I think we should just do it. That was maybe not a good answer, but yeah.
Deborah, I love your comments on that, especially the be braver, just do it.
Yeah, well, I was going to ask Minna a question about that. I love being brave and just doing stuff, but is this done sort of with transparency across the practice, so that you as a group decide, okay, this is a thing we're going to deprioritize, and then you let people know about that, you're upfront about it? Or is it done more at an individual level, saying to a patient, you have these 5 needs, and these are the ones I'm going to focus on? Because I think we all do that as clinicians, because we have to. So I'm curious how, because I would think the public messaging, and again, this may be system specific, but in the US, that would not go over well.
No, but I think, when we talk about de-implementation, I think we easily focus on quite sort of narrow topics for de-implementation, and we really need that. And when we talk about prioritization, it's also kind of a tendency to do that in sort of silos and how to prioritize, to deprioritize some certain intervention or something. But I think, and this also relates to the discussion about equity yesterday, that maybe, doing the prioritization of who should get more time with me is much more important, I think, to think more on a systems level. Like, instead of we need this narrow way of thinking about de-implementation, but we also need to think about what kind of system and what kind of booking time appointments and how to, the flow of patients in a healthcare center is facilitating prioritization and de-implementation of the stuff that we know that we should stop doing. And I think our discussions are more like that. So we don't say that we should not treat hypertension, blah, blah, blah. We're saying that we need to prioritize the patients with high blood pressure, with high HbA1c, with high risk factors and blah, 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 or with, I don't know, like that's the kind of work. Do you think that makes sense? Or
Yeah, no, that sounds also like population management, which I think makes a lot of sense. I also think you bring up a really important point about de-implementation and overuse versus this idea of prioritization, because if we tell the truth, we have to admit that there are very few services that we can say across the board represent overuse. And I think it's really hard to do that, and you end up having a pretty narrow focus.
Yeah.
And so what you really need to do is think in terms of the individual patient and how does this patient benefit from this, and is there a patient who would benefit more? It becomes a very complex conversation, and I think you're addressing that to some extent.
I fully agree, but that complexity can only be solved at the clinical level, I think.
Yeah.
So the responsibility from the policymakers and guideline makers is to not make us overwhelmed, but to give us the guidance and the evidence synthesis so that are more useful to us. And then that complexity, it has to be decided in the individual consultation, I think, because that's what patient-centeredness means, I think. Yeah.
I was just going to shift the conversation for a moment. I know that Janet Reynolds was at the microphone asking that question, but she's also the person I mentioned in my talk that screened her patients who are over 80. And I think it'd be interesting for the group to just hear for a moment about your experience, Janet.
We will have to get a microphone back to Janet. Hold on, we have to come down some steps to do that. And we will return the microphone to the person waiting to ask a question later. Okay, it's on its way.
Thanks, Wendy. So we were watching the news in Italy when ventilators were being sort of triaged to patients and thinking we would be in the same boat holding hands as our patients died without the care they wanted. So we took advantage and did a quality improvement approach to advanced care planning. And so we selected our highest risk patients, 85 and over, with 3 chronic diseases in their chart, and did outreach. Either our nurses or our physicians took the opportunity to look for, food security, social isolation during the initial lockdown when we sat around waiting for people to call, but actually COVID was very small compared to right now as we sit here in the audience without our masks on, and at least we're vaccinated, I guess. And so we also did what everyone else in the world did, is webinars. So we did a webinar for our patients and invited them to join to myth bust some of the COVID misinformation, as well as talking about advanced care planning, what it means, and how to get to the resources that you might want to talk with your family about, and then standardize how we record it. So I had a classic text from one of my partners saying, "Where do we record our goals of care?" And I said, "I don't know where you record it, I know where I do." And then we sort of generated a clinic-wide approach. And we're 17 family physicians with about 23,000 patients in our clinic. So having a standard place where that is documented so that when we called community paramedics to come assess our patients, we could forward that information in a timely way.
That's very impressive. What was your experience of the reaction in patients and the community?
Our patients are talking about it amongst themselves and with their families already, and they were, I think, overwhelmingly open to the conversation. Yeah,
that's great.
And my partner, Dr. Johnson, will add to it.
Because I think Janet knows I can never shut up. Ian, I'm originally from Glasgow, now live in Calgary. The video is still online, and so we still, and it's posted, it's on YouTube, and we linked it to our own clinic website, so I still send people to it, because to do an advanced care planning conversation properly takes probably 3 or 4 visits usually, and so if you can get them to sit down with their family and look at some of this information in advance, then I find that the conversations that I then have are more fruitful in terms of actually getting to where their goals are documented, not just what we think it should be, which I think is one of the challenges with advanced care planning. We quite often end up just telling people how it is, which is not really how it's supposed to be. So.
Okay, we're running low on time. I think we have time for 2 more questions. I'm going to, while we carry the mic back up to the person who surrendered it, I'm going to get one more online question from Thomas.
Yeah, one more online question. I think it goes to Deborah. Is there evidence that when reviewing endoscopy wait lists during the pandemic, that a significant proportion of referrals were not needed? Can this be leveraged to reduce overuse?
I'm not, that's a great question. I'm not actually aware of that evidence about waiting lists, so I'm curious to hear more details about it. But I do think that approaches like that can reduce overuse. And in fact, actually to Wendy's point about blood transfusions, in my center, the blood bank faculty actually started a review process to do something just like that. So when every single blood transfusion that is ordered is reviewed by a clinician before it's approved, which is a tremendous amount of work. And I think that's the answer to that question, I think ultimately is that would work to reduce overuse, but it would be very labor intensive, and it brings up interesting questions about how the information gets communicated back to the patient who's on a wait list and to the clinician who ordered it. But I think it's an excellent idea, and I'm curious about the evidence to which you alluded, because I'm not familiar with it.
Can I just interject there, Deborah? So we don't have faculty do that. We have the laboratory technicians do that. When the blood is ordered, the tech looks at it compared to a set of criteria. We teach the tech about it, and then the tech can call the nurse and say, oh, I see you ordered 2 units of blood. Could we give 1 and reevaluate? And so that we don't use faculty time. But I want to say in general, the concept of using criteria which trigger whether you can do the test or whatever is a very good, it's a good intervention in the right situation. So in Alberta, where you are in Calgary, if you want to do knee arthroscopy in a patient, your patient has to be screened at a knee and hip clinic. And those knee and hip clinics know that they're not useful in patients over 65. They don't help in osteoarthritis. They don't change the management. And so they screen them out. So, I mean, this is a very good approach to decreasing overuse, is screening criteria. And they can be applied in a lot of ways. Laboratory testing for vitamin D, like I said, knee arthroscopy, in this case, blood. So I just would add that.
Thank you. I'm going to move on quickly to probably our last question, and don't leave after that question because I have an announcement.
Yeah. Hi, James McCormack from UBC in Vancouver. A lot of discussion about lab values, and I recently looked into the concept of lab variation, and I was surprised to find things like hemoglobin A1C, when you get a measurement back, it's plus minus 5 to 10%. And when you get an LDL cholesterol measurement, it's plus minus 20 to 30%. And when you get a vitamin D, it's plus minus 30 to 40%. Yet labs don't report that variation. And I think, one, do you think that would be a useful thing for you to know? Because I think it fundamentally changes when you think about redoing another test. And if you think it's valuable, any thoughts on how we could get labs to report it? Because they all know it, but they will not report it.
I'd have to think about that a bit, James. It has to do with whether it will change clinical management. I think the problem with laboratory testing, well, there are many, but one is that, a certain 5% of tests will be abnormal just because you're running 20 of them. So I think the question is, in which cases would that range change your clinical management? So I'll give you an example of why I think it depends on that. Vitamin D levels may be low, but we don't need to test vitamin D levels. We just need to give people vitamin D if they live in the northern hemisphere. And so whether there's variation in that is just not important. It's probably low because we don't get enough sun, and we supplement without giving levels. So I think the answer is probably a more nuanced one about whether it would change clinical management.
Anyone else?
I completely agree with Wendy, but I would add that I do think that knowledge of that variation can be very helpful in patient communication around lab values where people, but I'm not sure that knowing the variation for each individual result would help clinicians, to Wendy's point, but I do think you bring up an important point that I often just discuss that with patients as a reason we don't need to do further testing. You know, we know that there's a lot of variation, and so we can leave it alone.
One quick thing people asked me earlier, someone asked on the phone about, I'll come back to it, just about that lab, that link. I put it in the chat box, but I'm not sure if everyone can see it. Some you might want to, in Theater 4, just share that in some way.
We cannot see the chat links here.
Okay, so it's choosingwiselycanada.org/labs-global-shortages. For those of you that wanted that, did you know that? Sorry, James, maybe you wanted to comment again. I just wanted to bring that up.
He's lost the mic, but he's saying no.
Oh.
Okay. I think we probably at time, we finished. Does anybody have any final bursting closing remarks among the panelists?
No, I'm fine, thanks.
Deb will be really, Minna will be really interested to hear what happens with your new global center for sustainable health. We didn't get to talk about that, but I'm very interested.
Thank you.
I'm glad you mentioned that. We should all check out Cochrane Sustainable Health, and there's a podcast and BMJ resources on it. I've already had a look, and it's really fascinating, and it stretches into other aspects of sustainability as well, not just the COVID context. So thank you so much. You've been a really interesting, engaging, fun panel to moderate. So thank you all.